We have a quorum now, and Professor Joseph Lee, the chair, is on his way. I will invite the deputations to take a seat first. We have sufficient time for today's public hearing. And we also need to invite the administration in, please. And we'll begin after they have taken a seat. Well, let's invite the administration in. Welcome to the panel on health services. I'm Dr. Pierre Chen, and I need to remind everybody that there are different channels available for different languages. And I need to remind deputations that when addressing the panels, you will not be covered by the protection and immunity provided under the Electoral Powers and Privileges Ordinance, Cap 382. Their written submissions will also not be covered by the ordinance. But rest assured, you can speak your mind. I just need to give you this reminder. And please also take note of the following. There are security measures, so please listen in silence to our meeting. Sorry, I have been quite anxious today because I was in a traffic jam. I was worried that I would not be able to come back in time. But anyway, let's follow the established procedure. I will invite the deputations to speak first, and then I will ask the administration to respond and also members to ask questions. This meeting will be adjourned at 1 p.m. We have 28 deputations here today. Some deputations may be on their way. They may be in a traffic jam as well. So I will first invite Mr. Lee Ka-ho from Civic Party to speak. Good morning. Review on mental health has been a topic for discussion for many years. This year, the review committee published a report, and we welcome this report. We also hope that the administration can implement the recommendations in the report to improve mental health in Hong Kong. This report consists of over 200 pages, and a total of 40 recommendations have been put forward. But I think the problems exceed the recommendations put forward. There is still room for improvement. For example, for services for young people and children, there are lengthy discussion in the report, but we do not have a lot of recommendations to improve the situation. Our young people and children nowadays face huge pressure ever since they are very young, and as a result we witness a number of student suicides in recent years. In 2016 there were 37, and as of end of April there are already 18 suicides this year. And the Education Bureau has also published a report on student suicide, and it was mentioned in the report that the majority of students who committed suicide suffered from mental problems. So if there is support in our healthcare system for them, it will be very helpful, because early intervention will help address their problems. However, as far as the hospital authority is concerned, in 2011-2012, the number of young people with mental problems rose from 19,000 to 200 in 2011-2012 to 28,000 in 2015-16, up by 50%. And yet, on the Hong Kong Island, mental health for students are only available in Queen Mary Hospital, and there is only another hospital in the Kowloon side. and there is a long waiting list. It is very difficult for them to get diagnosed. Apart from mental health service for young people, we believe that the government should also improve the whole mechanism, because right now the hospital authority is the only authority responsible for mental health problems among young people. It is a cross-disciplinary issue involving both the Social Welfare Department and Education Bureau. An authority should be set up for the long-term steering of the relevant policy. And that concludes my speech. Thank you. Next, Dr. Wong Ka-Fai. Thank you, Chairman. I'm from the Division of Nursing and Health Studies of the Hong Kong Open University, and the following is our views on the report. First, on promotion of mental health. In the report, it is said that the Department of Health is responsible for the promotion of psychological health, but there has been a lack of a systematic strategy in the past, and there hasn't been any follow-up work. And to avoid waste of resources and to make the promotional effort more effective, we think that there should be a lead department instead of taking a fragmented approach by different bureaus such as the Food and Health Bureau, Social Welfare Department, etc. And when promoting psychological health, we should also take greater note of prevention of mental illness, because public education can change our mindset and our behavior. Psychological health education should be included in the mainstream education. Second part, about mental health services for youth and children. Over the past 5 years, the demand has surged by 50%. It shows the lack of support and the problem with the existing service model. The hospitals are not putting people first. And for parents, they find it difficult to find help. And the consequence may be dire. If one has to wait for 5 years to consult a psychiatrist, it is far from satisfactory. We think that there should be a concrete plan to improve things, and there should be a timetable. For example, the manpower ratio should be improved. There should be more support for parents and use of resources. And there should also be the collaboration scheme between the education, social welfare, and healthcare sector should be extended to primary schools. The government should formulate policies and also to formulate policies on monitoring students' mental health. Third part, on mental health on adults. Despite the vast amount of resources deployed, the result is still not satisfactory. We believe that both the hardware and software should be improved. Public-private partnership should be implemented as far as hardware is concerned to shorten the waiting list. And there should also be public education so that patients can seek help earlier. And there should also be more mental wellness centers and other organizations to follow up on the cases. And we also need a good monitoring network for prevention's sake. And active aging is a good starting point for tackling the problem of senile dementia. Next, deputation. Thank you, Chairman. Now, the two deputations before me already gave their views from a professional perspective, but I'd like to cite some cases. In Kowloon Hospital, in a ward, there was a lady in her 50s, and she suffered from diabetes, but she had a very good appetite, and on one occasion she was eating the snacks shared by her inmates, and a male nurse, being responsible, approached her and told her not to have so many snacks because she's diabetic. And then the lady talked back, and then the male nurse got agitated and grabbed that lady patient and then tied her to her bed. And also in Kowloon Hospital, there was another case. A patient was too bored, and the patient took the mobile phone with him or with her, and then it was found out by the nurse, and then 7 female nurses then surrounded that female patient and asked where the mobile phone came from. Was it from the mother, or else they would forbid the mother from visiting her, and then the female patient got very emotional because her mother was mentioned, and then the leading nurse just said she is really crazy, and then both cases the patients lodged complaints, and according to the official response, the nurse or the nurses concerned were only dealing with the situation in the according to the established procedure, and there was no help for the patients because in the hospital wards the CCTVs cameras were there for the nurses to monitor the patients, not to take any video recording. I took this case to a social worker, and then according to the hospital authorities' written reply, the CCTV camera was installed for the purpose of monitoring the activities of patients.
There was no recording because if patients know there was recording, there might be negative emotions. I think that's self-contradictory. On one hand, you want to use the CCTV system to monitor the patients, yet why don't you record everything to protect everybody? When there is an incident, then you just listen to one side of the story. You listen to the nurses, or the patient attempted to grab some snack, and therefore the patient framed the nurse. Next. I want to, Mr. Lai, I want to focus on community support. Before I give my view, I want to share with you an incident in the community. Recently, a pro-establishment councillor issued a pamphlet. And what is on that pamphlet? A photo showing a group of policemen encircling a person who was thought to be a mental patient. I do not mention the name of the district councillor here. Now, the councillor said I received a fraction from the Kaifongs that the man loitering outside the market, making a lot of noise, asking for cigarettes from passers-by. The residents feel being harassed, and they're also concerned that the man might become out of control and attack somebody else. I try to understand the situation and also observe his behavior in the middle of the night. I have found that the situation is getting more and more serious. To ensure that he is given suitable treatment and care, and to let the residents feel at ease, I liaised with the departments concerned and sent him to the hospital for treatment. The pamphlet has given people the feeling that this is targeting at a person who may be a mental patient or who may be an ex-mental patient. That's something, and residents may feel that there's nothing special, and they feel that the district council has something good for the residents. In the promotion of community health care, the government has not done enough. Seriously inadequate. Residents have misunderstanding. Even district councillors don't know what to do when they receive such cases of complaint. And those in the front line may come into contact with mental patient or ex-mental patient, and there is no adequate support. In reviewing the mental health policy, the government should provide adequate support and training to frontline workers in the district level. As for the ICCMW, the service is inadequate in Tseung Kwan O. According to the SWD in Tseung Kwan O South and Tseung Kwan O North, ICCM, WD don't belong to Cheung Kwan Ho. Next. Now we have received the invitation to this public hearing. I really find it very puzzling. The information we have is not as much as the information in the hands of the administration. We are going to give our views, but I would like to quote the view of another member, this honorable member. You better tell me what. Now the report was started in 2013, and 4 years were spent, over 200 pages, many recommendations made. But we have seen there are a whole host of problems on the website of the HA concerning the waiting time for psychiatric patients is really scary. In Hong Kong East, for new appointments, 42 weeks. I really doubt whether this is really the case. And in Hong Kong West, the waiting time 127 weeks, 3 times longer. What's the logic? That's for Hong Kong East and Hong Kong West. If you if you go across the harbour to NT East, 165 weeks. You better tell me what has happened. If you say there are inadequate resources, then I want to tell you that a year or so ago, a friend from the media asked me, a journalist asked me, the government spent a lot of money on the handling of claims, of refugee claims. If the money is spent on medical policy, would that improve medical health service? I say my response was that we focus on medical policy. We do not speak on the use of other resources. But we can see that resources seem to be the reason for social problems. It's obvious that in terms of mental health service, mental health service is seriously inadequate. HA does not deny that it is a matter of resources, yet the government cuts the spending of the HA. Education is important. Earlier this year, there was an incident. It is found that Feng Shui Master, in his love letter, said that he forecast that there would be a mental health patient which would set fire and who will set fire and then start a fire and would hurt a lot of people. We responded to that. Your time is up. Next is Dr. Yip. I'm the Vice Chairman of the New People's Party. I work in a public hospital. I'm a psychiatrist. And concerning the report in terms of the inadequacy of manpower and resources, there is no solution. A doctor may have to attend to a patient, 30 patients in the morning, new cases in the morning, and 1 old case. There are inadequate clinical psychologists as well. Waiting time is long, and also the reappointments are also very few and far between. And there are also nurses who have to work, share the work of community psychiatric nurses, and the 1.47 ratio cannot be met. After a patient has been stabilized, the service may have to be stopped so that new cases can be taken up. Shortage manpower is an imminent problem. The second point is that there are people suffering from moderate mental health are also receiving treatment at the SOPCs. There is little follow-up at the family medicine level. But in fact, mild neurosis in the UK are followed up by family doctors, and only more serious cases are referred to psychiatrists. and after the patient has been stabilized, cases can be referred back to family doctors. Now, in fact, for mild or moderate physical illness, family doctors usually look after them. Why can't that be done for mental patients? I think there are only 4 types of drugs, antidepressants, and the 4 types of antidepressants and 2 types of tranquilizers. I think there should be a wider choice of drugs. And then for mental health is the halfway houses and also job placement are supervised by the SWT. As for family and marriage problems, they are related to social welfare policy. We are concerned about the mental health of children and also suicide of students. They are related to education policy. Helping the ex-mental patients to get jobs is the work of the Labor Department. There should be a high-level coordination committee. Next, your time is up. Mr. Cheng. Now, our view is of the Nursing Association as follows. There should be adequate planning for manpower. In 2017, the newly recruited no less than 180, but number of patients increased by 44,000. There is serious lack of manpower. In the public health system, the ratio between psychiatric nurse and patient is 1 to 50. There should be a reasonable ratio between nurse and patients in psychiatric wards. As for psychiatric community nurses, there are inadequate nurses. Manpower should be augmented. According to the nature of cases, the caseload should be adjusted suitably. There is a need to promote ambulatory care and community care. The SOPC and visit service are seriously inadequate. The government should increase resources in these areas. The case management program of the HA should be improved. For seriously mentally ill patient, case managers are not adequate. A case manager will have to take care of 50 to 80 serious cases. It is impossible to provide adequate follow-up and care. The government should strengthen the care management program, increase the number of psychiatric nurses, improve the workload of the case managers. There is a need to enhance protection of patients in hospitals. Patients have different needs and yet they are put in the same wards. This will lead to the frequent occurrence of bullying and increase the workload of nurses. There is a need to increase resources and nurses for psychiatric wards. There should be adequate supervision and monitoring. There is also the need to improve the design of psychiatric wards and separate patients with different needs. There is a need to regularly update the drug list from time to time, and drugs with less side effects should be used. On the whole, mental health policy in Hong Kong has been outdated over many years. There should be long-term mental health policy and provide adequate manpower resources to plug the loopholes and improve mental health care service in Hong Kong.
Next, Mr. Wong. I speak on behalf of my organization, which is concerned about family members of adult patients. Now, I think other deputations have made the same point. I'd like to increase the ratio of case manager to patients. At present is 1 to 78, and the threshold should be lowered. It should not be confined just to the seriously mentally ill, SMI, and it should also apply to other mental patients, not just those suffering from schizophrenia. And also, for elderly people aged 65 or above, they are neglected For case managers, they have such a huge workload. In the afternoon, they need to deal with some cases of ex-mental patients, and some ex-mental patients need to go to work as well. So sometimes to accommodate their work arrangements, they need to, the case managers would arrange for these ex-mental patients to come in the morning as well. And it's a serious problem. There may be questions put to the patients, for example, whether the patient suffered from any hallucination after taking the drugs, and what about drug compliance. And sometimes the boss could be just next to the patient at work, and the time slot available may not be convenient for the ex-mental patient to come. And through the telephone, if there are so many questions put to the patient, then the patient may lose his job. With increased manpower, the problem can be addressed, and timing can be more flexible, and the case manager's workload can be alleviated. The ex-mental patient's job will not be affected, and he will not suffer from a relapse. Next, Dr. Law. I'm chairman of the Association for the Concern of Mental Well-being of Family Members of Mental Patients. About this report published by the Review Committee, it is a lengthy report, but I'd like to focus on support for patients. Now, the Review Committee has recommended a review on the support service at the community level, such that better support can be provided to mental patients as well as their carers. We strongly agree with these recommendations. However, for Chapter 1, Paragraph 12 and Paragraph 15, there is no mentioning of how this actually can be implemented. To implement this policy, we recommend that we suggest to government that, first of all, there should be an enhanced peer support scheme for carers of mental patients, and the role of family members should be strengthened. Chapter 8 of this report referred to resources, and that is resources to support carers. And this is completely different from what I am talking about. My son suffers from schizophrenia, and my wife and I have been encouraging him to find a job, and luckily he has got a job, and he has to work on shifts. Even for a normal person, one would find it hard to adjust to working on shifts, let alone my son, who has to take medication. And that is why my wife and I have been visiting him at his place of work to support him. And even in the middle of the night when he gets off work, we would keep the light of our home on and prepare snacks for him. And after 6 months, he finally got used to his job, and he has rebuilt his confidence, and he has worked in the same organization for over 10 years. So family members are the most important carers, the closest carers to patients. So they need to be equipped with the knowledge and skills through training, including how they should spend time with their patients so as to give the best support to the patient. And also through the ambassador scheme, we can share experience with people with the same experience, like family members and also the ex-mental patients, so that they can get better support. Next. Thank you, Chairman. I'm the representative of the Alliance for the Concern of Family Members of Mental Patients of Baptist Oakland Social Service. The report mentions support for the carers, but it doesn't mention the participation of family members in the recovery of the patient's problem. And just the gentleman before me already talked about how important it was for the patient to have family support, and that is why it is said that a standing advisory committee should be set up according to the review committee. And the advisory committee should comprise members from the academia, the government, the hospitals, etc. But patients' family members are not represented. So our request is clear. First, family members should be represented in this advisory committee. Second, we hope to increase the ratio of service users so that we can make sure that our views can be heard on how the long-term development of mental health service should be. And we must enhance the service level and service quality. Next, I'm a member of an elderly patient, and in chapter 1 of the report it said that we should pay greater attention to elderly people suffering from mental health, but the focus is only on senile dementia. There may be other mental problems, and at present we lack the relevant services. I know of an elderly person suffering from depression, and the elderly person is unwilling to eat, and he is arranged to stay in the just an ordinary psychiatric ward, and it didn't help him. I also have another adult family member being arranged to stay in the same ward, and as mentioned by the previous deputation, my family member was bullied, was threatened, water was splashed on him, but he could only complain to us, the family members, because no staff members would deal with the problem. We've been told that the government doesn't have the resources to care for the elderly mental patients, and therefore there is an urgent need to increase resources in this regard. Next, I think many ex-mental patients and their family members face obvious financial hardship because sometimes carers need to, say, change their work pattern and to take on additional financial burden for taking care of their for their ill family members. But there is no clear support for these carers, apart from widening the scope of the subsidized drugs in the drug formulary. There is no other recommendation in the report. We believe more support should be given to the families. For example, some of the families may be aging, and for Oi Kwan Social Service Center, earlier this year we conducted a survey. We identified 3 factors for causing emotional disturbance to the family members. One is the aging of family members, and also patients suffering from chronic diseases, and also patients that require long-term medical expenses. And also the third factor, families facing financial difficulties. For example, a family consisting of members with various degrees of disabilities. There is a pilot scheme that provides subsidy to the families. The idea is good, but in terms of actual implementation, the threshold is very high. The subsidy will only be granted to families waiting for a long-term hostel place, but in fact there are far more family suffering from the same problem, and therefore the subsidy won't help many families, and because of the complex application procedures, many families are deterred. And maybe the family members do not know that they can apply for this subsidy. And like I said just now, many carers will need to change from full-time to part-time, or they may even have to quit their jobs. And it is very difficult. According to our survey conducted since last year, close to 60% of the family members expressed that their work has been affected because of the need to take care of the family members. They may need to take days off to accompany the patients to follow up medical appointments. And taking days off in Hong Kong is difficult. Is there any policy to give more support to family members of patients? Next, Ms. Ng. I speak on behalf of the Association of ADHD Patients. I welcome this report. I can see that it contains a lot of information in terms of mental health service for young people and children. In recent years, the HA has received 50% more cases of ADHD, but there is no recommendation in this regard. Even for other recommendations, I don't see how they can be implemented. Well, it is said that for social there should be collaboration among the social healthcare and sectors as well as the families. And also for education, since there is a school-based approach, schools can refuse to allow professional teams to intervene. And even if professional teams can intervene, because of the heavy workload of teachers, can schools really collaborate with this interdisciplinary professional teams? And are there ways to increase manpower in schools? For example, one SEN student can substitute 3 normal students so that we can increase the ratio and look after their mental health. In terms of on-the-job training for social workers, there should be more training on SEN because right now social workers learn about SEN in textbooks only, and waiting time is still very long at the moment. The report also recommends more doctors be trained in the private sector so that referrals can be made, but this will sacrifice the health of some patients suffering from chronic conditions, because for children and young people, they are still in their adolescence. They may need the close attention by doctors, and there should also be more training for adult ADHD, because at present there is insufficient knowledge on the condition as well as the medication available. Support for family, for parents, and emotional support at present is lacking. We hope that the government can consider providing direct subsidies to mutual aid organizations such as ours, so that we can provide a more effective support for them. And also there should be disability allowance and other forms of subsidies, so that whilst they are waiting for a place, they can pay for various expenses. Thank you.
Next, Ms. Pong. Chairman, councillors, those who are concerned about mental health patients, are from the Oikwan service. We want to share with you our frontline service, because the report has not given any specific proposals. Recently, there's a case, a male 12 in Banwan school. In primary 6, when he was in primary 6, a parent divorced. The mother is a new immigrant, and the boy lived with the mother. And when he's in secondary school, he tried to kill himself. The tragedy was stopped by other students and the teacher. And there was Also, the student also suffered from cognitive disorder. He is concerned about his mother, and also he is concerned about his studies, and therefore he suffered from mental illness. In the process of development and change, children suffer from pressure, and if there are family problems as well, then the child will maybe suffer from mental illness. In our survey on emotional situation, about 30% of the secondary school and primary school students have reached a level of clinical concern. And we propose to strengthen surveys in schools so as to identify mental problems of children at an early stage. And mental health education should be put into the regular curriculum so that students understand mental health and learn how to help themselves and seek help. The review also proposes to promote public education, but it does not target on the discrimination against mental patients. In newspapers, features, in TV series, people have the impression that mental health means violence, and this deter mental health patients and their family members from seeking help and seeking medical treatment. Discrimination will marginalize the mental health patients. They will become alienated. Nobody cares for them, and tragedies may ensue. There's a need to know more and learn more about the mental health patients. Next, Ms. Lam. I come from a self-help organization. I hope that there should be a one-stop service to the mental patients. There should be a comprehensive policy which is specific and targeted. As said by the speaker before me, I fully agree with her. From March 2015 to April 2017, over 60 children killed themselves. Where does the pressure come from? Hong Kong is speedy, Hong Kong is full of pressure, and Hong Kong aims at excellence. And parents have high expectations towards their children. They don't want their children to be marginalized by society. They don't want their children to get low-paid jobs in the future. Therefore, they put pressure on their children, hoping that they can excel. I hope the government can reduce class size, reduce the pressure of studying on students, so that students can learn happily. They can, and there should be more emotional support given to students, and psychological pressure should be taken away from them. I hope that mental health can be put into the ordinary curriculum so that students learn how to improve their emotional health. There's a need to remove discrimination so that members of the public can deal with, can live with mental patients in harmony in community. As for the shortage of manpower, it is a long-standing problem. The government has to find a solution to this. If there is public and private partnership, then there should be adequate supervision and there should be adequate follow-up on the outcomes. Well, I also hope that traditional Chinese medicine and acupuncture can also be used to bring relief to patients. Thank you. Your time is up. Next, Mr. C. I'm a member of the Oikwan service, I suggest that the administration should provide support in terms of job placement. At present, there is not adequate service in helping the ex-mental patients to get jobs. And when a ex-mental patient seeks sick leave in order to attend a consultation, that may affect their jobs. Therefore, there should be evening consultation sessions for ex-mental patients so as to protect their jobs. Number two, there's a need to provide hostel places in the community. Most of the hostel places are in the new territories, and this have become an impediment for the ex-mental patients to be integrated into society. If the hostel places are in the urban area, this will enable them to have ready access to medical service and other social service. At present, there are more and more young people suffering from psychiatric or from mental illnesses. 40% of the students are suffering. There should be a better service provided to students. The students, well, there is also the issue of stigmatization if students are found to have mental illness, and there is also a need to care for students of special needs. Now, if mental patients, young mental patients have taken drugs for treatment, that may affect their behavior, and that will also affect their studies. Now, students, children need to have adequate space and time so that they are not just living for the purpose of sitting for examinations. Say an example is that an artist has made use of used tires to set up some playing equipment for children in a sitting out area. I think this is a good example. I think we should provide funding to people who can provide good service to children. Next, Ms. Yun. Thank you, Chairman. As for mental health policy, we have been waiting for this for more than a decade. Now, we have many speakers who have pointed out the problems in mental health policy and services. The report referred to the mental health policy, quote unquote, it is inadequate, it is not comprehensive. As for the hospital, the hardware and software, there has been no improvement and no mentioning in the report. As for evening consultation sessions, we have been asking for that, and it's not mentioned in the paper. Rehabilitation is very important, but the report has not spoken much on this. As for hostel places, not a word has been said in this report. How much is the demand for hostel service? And nobody knows. And the additional places in Siu Lam are not adequate, and also Siu Lam is remote, as said by the gentleman before me. The Cambridge was an example. There was a problem of supervision of private homes, and the report didn't say a word on this. As for case management, there is a need to increase the number of case managers, and the ratio should be improved to 1 to 40. As for ICCMWs, in fact, they also have heavy workload. Is there any service standard and any ratio? No, not a word on this. As for ICCMWs, they provide community service and community support, but there are many problems. An ICCMW serves 330,000 people, and some centers don't have permanent offices. The government, how can the government help them? Not a word is said in the report. Just now, Ms. Chan referred to the participation of ex-mental patients and family members. In May 2013, when the review committee was set up, there was a consultation, and we asked for a representative of ex-mental patient. The person participated in the meeting, but the person was frustrated, and the ex-mental patient felt frustrated and also couldn't do anything. The ex-mental patient felt alone. I think we need the help of Professor Chen. Thank you. I'm from a self-help patient group of a Christian fellowship. I appreciate some of the points raised in the report, but from the point of view of the community, I find the report is sort of a lame duck. Good medical services have to be supported by a good community. In the past 4 years, only the SFB wrote this report, and there was no suitable policy or appropriate policy from the LWB. We need medical rehabilitation as well as rehabilitation in community. Otherwise, this policy is just a lame duck. Now, an ex-mental patient is discharged and lives in a private care home. He lives there, just sleep and eat, just like an ordinary animal. That is living, but that is no life, and that is no purpose of living. One day, that ex-mental patient slipped and fell and hurt his skull, and his brain was also hurt, and then he suffered. He couldn't move. The family member complained to me. Nobody was accountable. Nobody is held responsible. Nobody cares. And so, but the burden rests on the family member. If there is suitable supervision of private homes, this tragedy wouldn't have occurred. As for mental health education, in 2013, there was the review committee. Dr. Ko asked us for a consultation meeting, and I talked to Dr. Ko to provide good mental health service. There is a need to deal with stigmatization.
In the past 4 years, I understand that the government and other NGOs have done a lot in promoting public education. But what about the result? In 2016, a medical journal published an article in relation to Hong Kong's situation. There was a telephone poll with 1,000 respondents, and the survey finds that over 70% of respondents expressed that they will not listen to the views of SMI, seriously mentally ill, and 70% of them said that they would not hire people with SMI, and 70% of them said that they would prefer other candidates than SMIs. Next, I'm a member of the ADHD Association. In 2007. There was another report on young people and children. I supported that. In 2007, well, that was a bit late, but it wasn't until then that ADHD and learning disabilities were included. And 10 years down the road, because of a greater degree of awareness and more cases diagnosed and enhanced knowledge, we have more cases now, but we don't have sufficient doctors. We have pediatricians who have undergone training to help take up these cases, but the waiting list is still 3 years. Well, back then, my child waited for 2.5 years before he finally got diagnosed and got a prescription. So you talked about many new doctors graduating from medical schools, but how many doctors received the relevant training? And we can't only rely on medication. We need a team to help these patients, because if the patient has poor drug compliance, then you can have the most undesirable result. If more resources can be provided, you can better support them, especially support for carers, because carers really have a hard time, and many of these carers are depressed. They suffer from depression, and they also need to consult a doctor as well. So it's fortunate for me to be able to speak here. But if there aren't more resources, then you could see another patient. Before 2007, before ADHD was included as a classified disease, many young people not being diagnosed found it very difficult. They were in a plight. Now that they have progressed from ADHD to other mental conditions such as depression, etc., or bipolar, I hope that more resources can be given to support carers and parents, and standing advisory committee should be set up. There should not be a committee set up just 10 years later. From children to adults, the transition is critical. ADHD is given a very low priority because there is no suicidal attempt. The condition is not serious, but if these ADHD children are neglected, then they can easily turn into those having violent or bipolar symptoms. Next. I am the representative of the Hong Kong Social Workers General Union. I have collected views from frontline social workers and users. First, we would like to set up a dedicated social worker team for young people. On page 92 of the report, it is said that the service scope is sufficient at the moment, but what about services for young people? For ICCMWs, these centers target users age about 15, and for others, they rely on HA service, and they need to be referred to HA first and be diagnosed first. And it is problematic because we therefore must rely on schools, on parents. We need the cooperation of parents and schools to have sufficient manpower to take care of these students. And we have been seeing student suicide cases. And we therefore identified this gap in services for young people and children. And therefore, we believe that a dedicated social worker team should be set up to fill this gap. Second point, we urge the administration to face up to this issue, and that is for ICCMWs. Many of them still do not have a permanent location. We have 20-odd such ICCMWs set up, but 9 of them at present still don't have a permanent address. And just like what the recent movie Dialogue said, you cannot always outsource everything to others. The ICCMW has been outsourced to us for us to find a permanent address. It is a difficult job because, for example, in a public housing estate, there could be a vacant unit, but it is to be shared by the housing department and community organizations, and Of course, the Social Welfare Department is represented, but this is not just a problem with the Social Welfare Department. Other government departments should also lend a hand. And we have government officials who are female. And in one example, the ICCMW doesn't have any permanent address, and it has to be housed in a halfway house for male inmates. So imagine for the ICCMW serving female users, it's very difficult and very embarrassing for the female user to use the male toilet. So you need to fix this problem with ICCMW in finding permanent locations. All the deputations have spoken, and I think it's time for Undersecretary to respond to the major issues expressed, for example, in terms of services provided, support for parents, and also services for young people and children. I'll let you respond first before I open the floor for questions from members. For deputations, well, in a moment, if members wish to ask you questions, feel free to answer them. Undersecretary. Thank you, Chairman, and I thank deputations and individuals for coming to tell us your views once again. In fact, at the stage of consultation by the review committee, some organizations and individuals already gave us your views, and we have published quite a detailed report since then. We have been here, and we're here to listen to your views, and definitely we need to follow up on many issues. As said, we are going to set up a standing advisory committee to follow up on our work, and we're also going to review the our work. And of course, in the report, we have received some 40 recommendations. We need time to work with different departments and units. We need to plan and strive for resources for implementing these recommendations. We've also suggested some pilot programs, and I think that you can refer to them in the report. You mentioned adults, elderly, young people, and health education, promotion. And I'd also like to respond to the points raised by Dr. Wong on the promotion of mental health. We should not take a fragmented approach. In fact, in terms of promoting mental health in Hong Kong, we do have a strategy. We have asked for additional resources for this purpose. On the one hand, we understand that the stigmatization and labeling still exists in the community, but the crux of the matter is if we can do well in our promotional effort, if we understand what mental health means and how we can help those with mental problems, we can do away with stigmatization. So we do have a strategy. Public education is one prong, and we also, on the other prong, work with other NGOs so that we can get in touch with the community and so that we can promote the understanding of mental health more extensively. For adult and young persons, we have specific strategies. We also enhance on our existing efforts to address the inadequacies at the moment. There are also ongoing initiatives because demand for some of the services continue to surge, so we continue to improve our services. And we also have some standing committees which are new, which will look into the issue of new services As for resources, I think many deputations already touched upon this issue. Manpower is our greatest constraint, and we have undertaken that more resources will be allocated, be it psychiatrists or nurses. There will be additional manpower both in the Department of Health and the Hospital Authority, so that, for example, for the case manager-patient ratio, we can improve the ratio. As for public-private partnership schemes, this also helps address the issue of long waiting time. In the report, and just now some deputations also mentioned that it is hoped that family doctors and general physicians can take up more stable cases in which patients are stable or with mild conditions. As at the same time SOPC is necessary, I want to reassure you that the SOPC will continue to take up cases. They would not pass on the buck to others. We're just talking about patients with more moderate conditions, and that family doctors can be engaged to help them. And at the same time, some deputations mentioned hardware, for example, whether we can update the drug formulary, and again, this is an ongoing initiative. As to whether there will be more community or mental wellness centers, we understand the need. I will follow up on this aspect of the hardware, and there should be more collaboration between the social welfare and healthcare sector. This is, in fact, one of our policy objectives, because for mental patients or people with mental problems, from prevention, treatment to recovery, if we can provide a one-stop service after they return to the community, we'll be able to fulfill our policy objective, and this is also the global trend. And that is why we must enhance our efforts at the community level. Collaboration across bureaus or departments is of course a necessity, and that is why we have some pilot schemes to demonstrate how we collaborate with the Education Bureau, Food and Health Bureau, and the Hospital Authority, and also with Labor and Welfare Bureau. And these two bureaus also participate in the review committee. We also have a representative from the Labor and Welfare Bureau today. As for the standing committee to be set up, I have also heard views from deputations on that. As I said just now, for new schemes, new services, this standing committee can follow up on them, and the committee can also review our performance. I hope that if we're not up to standard, the standing committee can ask us to keep up, and also we keep all options open at the moment.
Now we need experts, we need stakeholders from the public and private sector. Family members and patients are also important. In the review committee, there are representatives of ex-mental patients and the family members. In the standing committee, and we will have them as well. So-called has reminded us that some even are in the community, their participation may not be adequate. We will pay attention to this as well. As for the participation of carers and family members, this is very important. Several speakers have referred to community programs and peer programs. We attach importance to these programs. The FHB will do its best in promoting this. As for enhancing the service of HA, the provision for evening consultation for ex-mental patients, so that they don't need to take leave during daytime. We need to look into this as to the ways and means of improving our service. I hope that you can appreciate that we do have a mental health policy. We hope to emphasize on interdepartmental cooperation. And we also want to emphasize on rehabilitation in the community. We do not pass the buck to the community at large. We need to deal with serious cases. We also need to increase the number of psychiatric nurses. Some clinics and many tasks require the participation of nurses. And we've heard the view of the Nursing Association. We hope that this standing committee can focus your attention and your views. And we also follow up on the suggestions that we have not yet have implemented. Concerning ICCMW offices or a base for ICCMW, and also the elderly psychiatric service, has it disappeared from the HA's service list? And many have spoken on the support for carers. It is not in the report. Would you respond to these points? And also one more. For the ADHD young people, it seems that there is no service for them. Some of the work falls within the LWB's portfolio. Maybe the LWB representative can speak on this, and HA can also speak on the services. Chairman, concerning the office for ICCMWs, this is our concern. In 2010, we started to have ICCMWs. We integrated community support services to make it a comprehensive one. The services actually at that time didn't have any office. Well, at that time, only 5 centers have an office. In the past 5 years, we have got altogether 15 offices for the ICCMWs, and we hope that we can have another 5. And there are still 4 more outstanding, and we have added them in some development. In some developments, they are at different stages of development. We are unable to disclose the details now. And if these centers don't have offices, we encourage the service providers to rent offices in commercial property. The SWD has not contracted out the service to the NGOs. In 2010, when the ICCMW were established, we knew there was the need to have offices for them. But we want to provide the service first, so we started the service while we are looking for offices. I hope that you can be assured that we'll continue to identify suitable offices for the ICCMWs. As for the carers, but there was a case in which a female patient stayed in a male mental health hostel. It was embarrassing, wasn't it? I didn't have the details of the case. After the meeting, I tried to understand the details. As for ICCMWs which don't have an office, they do rent private commercial buildings as offices, and we'll try to improve the situation. What about the carers? Many have referred to the carers. Our task is to care for the carers as well. 2 years ago, we added 2 ASWOs to our ICCMWs and also family support centers. They are tasked to support the carers. As for the carers allowance that was implemented last year, we are now reviewing the situation. We will listen to your views. If we are to regularize this, we will find suitable measures to improve that. As for carers organizations and patient organizations, they do have support from the SWD, though not a big amount of support every year. We support 6 self-help associations. We spend about 2 million for 2 years. Perhaps the HA will speak on psychogeriatric service and also the ADHD young patients. As for psychogeriatric service, there is the service available. We have seen the increase in number of patients. As for outpatient service, according to the needs of patients, when a patient reaches a certain age, they will be followed up by the adult psychiatric service or psychogeriatric service. We consider the needs of each case. The case manager is more familiar with the patient, whether the case is looked after by the case manager or whether the patient is referred to the psychiatric outreaching team. It will be dependent on the decision of the case manager and according to the situation of the patient. That is inadequate manpower. We'll consider this mode of service and try to improve the service. As for the continuing support to ADHD children, since 2007, ADHD has been included into the list, and the number of patients has been increasing drastically. After patients have become 18, they will be referred to the adult psychiatric service. We will have case conferences with the children and youth psychiatric teams in respect of dealing with the cases. And there can also be training courses for our adult psychiatric service colleagues to update their skills and knowledge. And what about the hostel places and also supervision of private homes or private hostels? Yes, for the supervision of private hostels, there was a reorganization recently. We set up a special team to supervise the homes and step up our prosecution. We also have a number of measures to help private homes to enhance their service. We send consultants to help the homes for mental patients to give advice to these private homes. We also have subsidized homes. About 3,000 places available for long-term care and also for half-day care. The queue is getting longer. We are working on our plans in the coming 4 years. There will be about 480 odd new places. And the use of private land for welfare services will also provide another 400 odd places. We've also identified sites for the construction of homes for caring for the mental patients. We also have a board place scheme. This year we have bought an additional 150 places, altogether 600 odd places are available to the mental patients. These places are for ex-mental patients or for whom? For ex-mental patients and also for the mildly mentally disabled. I open the floor to members. We'll have our meeting until 1 p.m. Dr. Chung, Mr. Hangpan, Dr. Chen, and so on and so forth. Dr. Fernando Chung. Having heard the complaints of the deputations, I can only say that the mental health service in Hong Kong is full of holes. Now you spend just $70 odd million per year on mental health care. First of all, there should be cooperation between the medical sector, the community service sector, and the education sector. Yet, there is no representative of the Education Bureau. Now, there are students who kill themselves. They kill themselves on campus. The Education Bureau is not represented here. And there is a pilot scheme for schools. According to the report, there is stigmatization of mental patients. Surveys have shown that the situation of discrimination is getting more and more serious. So is your education program successful? We've been talking for years on ICCMW's offices and evening consultation sessions and support for self-help groups. The AD, Mr. Fong, said that about $2 million dollars. But in fact, a self-help organization is given $150,000 per year. Last year, there was a cut on funding. $150,000 per year cannot even get you one staff member. What sort of support is it? As for waiting time of young person and children for psychiatric service, the queue is getting longer and longer, but according to Dr. Yu, she would talk to the doctors. I don't know whether they just talk to you and then the problem is solved. I really don't know where to start to solve the problem. So I just want to ask this practical question. You say there will be a standing advisory committee or standing consultative committee, and the committee has all sorts of people represented. When will it start? What is the terms of reference of that standing consultative or advisory committee? What departments will be represented? Just now, Ms. Yun also said that just one ex-mental patient is put on this committee and he or she represents all of the ex-mental patients. That's not possible. Do you have any plan to get the ex-mental patients in, to get the advocates in, to get the family members in? I mean, into this committee.
And the Secretary. Thank you, Dr. Zhang. And he has reminded us the various issues. Let me just respond to the point about standing committee. Our preliminary idea is that there will be different stakeholders represented, comprising scholars, experts, patients, ex-patients, family members, also representatives from both the public and private healthcare sectors. Of course, we keep all options open. Your views are welcome. We hope to set up this committee in the second half of this year. After the report has been published, I believe that different departments and organizations are following up on them, and this is what we plan at this stage. Of course, we will follow up on the 40 recommendations put forward in this report. We'll also review our existing work and see if there is room for improvement and what should be continued. And we will also review the pilot schemes, promotional schemes. There will be a review on these initiatives, and we may also come up with new proposals for different parties to follow up on. All right, so keeping all options open, Chairman, it seems that they have just settled on their project titles, and they will just leave everything to the next administration. At this stage, in terms of the proposed terms of reference and the public's views on that, can you at least tell us before the next administration what is the proposed terms of reference? And the Secretary, can you give us a supplementary paper? I will go back and see if the terms of reference is ready. I think Dr. Zhang's request is very clear. He hopes to see the terms of reference of this standing committee. Maybe you can consult us. Give us information later. Next, Mr. Ban Chen. Thank you, Chairman. The administration has conducted this review on mental health. I welcome it, but I've read the report, and there are a number of things I'd like to talk about. First, on hospital beds, second, case manager, and third, medication. For hospital beds, in the report, I don't really see any mentioning of hospital beds. For psychiatric illnesses or acute conditions, as I understand, there is a severe shortage of hospital beds. It seems that there is no additional beds for acute conditions. A few months ago, I visited Taipo Hospital, and in fact, the hospital was so crammed. So what happens if there are more A&E cases coming in, if the hospital was already so crammed? And their reply was that for patients with more stable conditions, they would be released in the community. Now, to my understanding, perhaps for some patients, their condition may not be so stable, but because of a shortage of hospital beds, they might be discharged, and in just a few days' time, they might come back to the hospital again. So this is a vicious circle, and it has to do with manpower as well. At night, there is only one nurse and another assistant overseeing several dozen patients. I don't see this being mentioned in the report. We need more resources from the front line, especially for the problem I mentioned. Second point, case manager. One case manager at present takes up 50 cases. It is extremely difficult. You propose to lower the ratio to 1 to 40, but comparing to other jurisdictions, 1 to 40 is still too high. For the case manager to take up so many cases, that he may face so much pressure that he would quit, and that there would be another case manager coming on stream, and then because of the constant changing of case managers, and because the new recruits may not be experienced in identifying issues, problems may occur. Now, case managers follow up on patients in the community, and if something goes wrong, then a problem may occur. And we should also be sympathetic because the case manager's workload is very huge. I hope that the ratio of 1 to 40 can be further lowered. Third point about medication, we have 150,000 patients receiving psychiatric treatment at the moment. 75,000 of them receive new drugs, whereas others, they use traditional drugs with serious side effects. And I think one common problem for mental patients is poor drug compliance. And we understand in other jurisdictions, sometimes they may only be administered an injection once every 3 months. And even if the patient doesn't come back for follow-up treatment, you still have 1 year's buffer to locate that patient. So why can't we use new drugs in the form of injections which are effective? Why can't we do that? In this report, I don't see any new ideas proposed. I wonder if you are just sweeping problems under the rug. I'm not happy about this. I'm not really happy about this. I'll see if the administration has any response. Thank you, Mr. Chen, for your comment. And let me first respond to your point, and then the HA colleague can supplement. On hospital beds, of course, the patient is required to be hospitalized. We will not ask the patient to be discharged simply for releasing hospital beds. And the HA can supplement on that. I think the global trend is that when the mental patient is well enough, he should be released into the community, to his own community. We agree that there is a shortage of manpower. We've also at the same time allocated $73 million to the HA to enhance the support for mental health, including healthcare manpower. And as for the case manager, I think Mr. Chen is right. The ratio is not satisfactory at the moment. We hope to lower the ratio to 1 to 40, and we will be progressive. When we increase manpower for the healthcare sector, we will gradually lower the ratio. As for medication, we understand that there are some so-called new drugs and old drugs, but old drugs doesn't mean that they're not effective. It depends on the clinical diagnosis and the need of the patients. If new drugs are necessary for some patients, the HA doctors can, based on the clinical diagnosis, prescribe these new drugs. I think the HA can supplement. Let me talk about medication. In the past few years, the HA has allocated additional resources to procure new drugs. At this stage, all the psychiatric drugs all antidepressants are first-line drugs. It can be prescribed by other doctors as well. I can just say that even for new drugs, there are side effects different from the side effects for old drugs. I think it's up to the clinician to decide what is the most suitable medication for the patient. As for the so-called expensive new drugs in the form of injection, we have introduced these injections. As for the injection mentioned by Mr. Chan, that only one injection is needed once every 3 months, we have only introduced this drug this quarter of this year. And I think that doctors in various hospital clusters would review the effectiveness of these injected drugs. They'll see if the 3-month injection is better than the 1-month ones. How about, Chairman, asking them to report back to us once some study outcomes are ready. I think it's very difficult to discuss the specific drugs at the panel meetings. Perhaps if you have the reports, please forward them to us, but we're not going to discuss the specific use of drugs. We'll only discuss policy issues. Deputy Chair. Well, as mentioned just now, mental health is an interdisciplinary issue, so I need to ask the government this first question. Today, why haven't we got any representative from the Education Bureau? Have we invited them, or has the Education Bureau representative gone on a duty visit? And also on page 147, there was the PS of for education, and then page 193, only a senior education officer from the Education Bureau was invited. So I want to know more about the collaboration between bureaus. And also, are there any examples in your report showing collaboration between Education Bureau, Labor and Welfare, and Food and Health Bureau? And which will be the lead bureau, Education, Food and Health, or Labor and Welfare in a future collaboration? This is a specific question. I look forward to your reply. And I'd like to talk to this psychiatrist working in the public sector. Now, the first question is this. In your line of work, as a psychiatrist in the public sector, how many patients do you receive every day? And also about outpatient clinic for mental patients at night. What is your understanding of that as a doctor in the public sector? Third point, are all suicide cases relevant to mental issues? And is it the case that they can be prevented 100%? Just 3 questions first. Dr. Yu, if you don't mind. Thank you, Chairman. Thank you, Dr. Chen, for your questions. For public doctors working for outpatient clinics, we have the morning and afternoon sessions. We have more patients in the morning, roughly 30 old cases. There may be new cases in the afternoon. There may be 20 odd old cases plus some new cases. So basically, you're talking about some 50 cases a day. Second question. For nighttime psychiatric outpatient clinic, we believe that it would be helpful for patients because, say, for patients to come to their follow-up appointment, they may have just switched jobs and it would be difficult for them to take a day off to come. Well, although we can the patient can decide not to put down the discipline in the medical chit. With technological advances, if you just put down which block, which floor, then the boss can still find out very easily. We understand the patient's concern, but for nighttime outpatient clinic, not only doctors will be involved, we also need pharmacists and other support staff. Third question. From a psychiatrist's perspective,
international studies have shown that 80 to 90% of cases had detectable psychiatric illnesses. So this is one of the main reasons, but not 100%. Sometimes we come across cases who do not suffer from depression or not in a sort of relapse. But there may be an incident which cause one to be emotional and an emotional burst causing someone to harm oneself. According to the present-day medical skills, even if we adopt the strictest assessment, a very experienced doctor together with actuarial methods may not be able to forecast whether a person will commit suicide or not 100% accurate, 100% accuracy. Now, doctor, you look after 30 patients in the morning and 20 patients in the afternoon. How many minutes per patient? I'm not familiar with the situation. A few minutes per patient only. There's sometimes for those who are who are relatively stable, we spend less time. We attend to about 30 patients in the morning. We have to leave some time for patients who need longer time of attention. We need to understand the situation by spending more time, and we may have to talk with the patient on whether the patient should be admitted into the hospital, or we may therefore need more time for such cases. Sometimes the patient may be a bit confused. For example, the patient suffer from sexual harassment. We cannot just spend a few minutes on that patient. We have to listen to the patient, provide some counseling to the patient. I leave some time to the Bureau on why there is no representative from the Education Bureau. Thank you, Chairman.
教育局嗰個參與咧係非常之重要嘅。
We believe that the participation of the Education Bureau is very important. In our review committee, the Education Bureau has all along been involved. In the new standing committee, we will invite the Education Bureau to send a representative to the committee. Though today there is no representative present, any view concerning the Education Bureau will be referred to the Bureau. As for the pilot scheme, for example, the cooperation scheme and also another pilot scheme, they are led by the FSB. I don't know. I think he didn't ask for the two examples. In fact, he asked for who would take the lead in the various programs and schemes. If there is any pilot scheme proposed by or discussed by the standing committee, then depending on the nature of the scheme, some may be led by us, some may be led by other bureaus. Mr. Poon, I think the deputations are coming. I heard that they welcome the report, but there can still be a lot of improvement. Several policy bureaus are involved. FSB, LWB, and EB. And many departments will be involved in implementing the policy. The Undersecretary said that there will be a standing committee. It's also in the policy address. You are now preparing for that, and it may be set up in the second quarter. This is only an advisory committee. The departments are responsible for implementation. Dr. Chen asked who will take the lead. Shouldn't there be a mental health authority to take the lead? I hope the Bureau will respond to that. A deputation said that in some districts, the new case will be attended to within 42 minutes, some 127 weeks, in new territories 165 weeks before a new case is attended to. So the patient will have to wait for 165 weeks before he or she is given the first dose of medicine. 8.5% of resources are spent on mental illnesses. So there is a long queue. So how can you deal with the problem? As for adding manpower, this is very important. 40 recommendations covering 20 areas. Many are related to increasing manpower. I don't know what is your overall manpower situation and how the bureaus are going to deal with that, whether it's case manager or nurses or other areas. Are there specific plans to augment your manpower? Thank you. Thank you, Mr. Pond. As for the interdepartmental and inter-bureau cooperation, this is a mainstream opinion in the review committee report, and it is a task which we have to achieve. The two pilot schemes have shown that there is interdepartmental cooperation. As for the setting up of a mental health bureau or authority, we don't believe there is a need. There is the Standing Advisory Committee, which have representatives from different bureaus and departments. According to our policy, a lot of work will have to be implemented by different units such as the HA or DH or other departments. The Standing Advisory Committee will discuss, and then afterwards, if a proposal is endorsed, we will seek resources to implement the recommendations. As for waiting time, the HA can respond. Some of the specialties can deal with patients across clusters, so the HA can speak on the waiting time. As for manpower, the FSB has added resources to the HA to increase manpower. As you all know, it takes time to train up nurses and doctors. They've got the resources. If they have any specific plan, I hope the HA will share the plan with us. Thank you. Dr. Yu. As the waiting time of special clinics, pressure is high for different specialties. As for psychiatric clinic, vetted manpower to these psychiatric outpatient clinics for young people and children. We also strengthen our teams to deal with the backlog of new cases. We will also adopted a new approach through the nurse clinics and also paramedic service. We try to understand the situation of the patients beforehand so as to facilitate the doctors and enable the doctors to have a better understanding of the patients beforehand so that a scheme for treating the patient can be drawn up very quickly. And there is also the coordination of training and also medication for patients. We also want to enhance the primary health care so as to deal with mild and stable cases. In 2011, in primary health care level, we have started the service to help mild and common mental illnesses so that they don't need to go to the specialist clinics. That will help to relieve the pressure on the specialist clinic service. Mrs. Xiu, starting from with regard to mental health care review, we should start with WHO. No health without mental health. As for this report, we have been waiting this for a very long time. They said they spent a year on this, but they spent altogether 4 years. They spend more time, but it doesn't turn out good work. It just turns out some small things. Now, the Undersecretary is concerned about mental health. No wonder many deputations are here, and they are very anxious to express their views. They hope that you understand the problem more thoroughly. Well, I'm disappointed by this report. No health without mental health is the motto. I expect that the report will touch on the whole policy area. But if you look at the report, you can see that they focus on the review of the operational level rather than the review on the principles. We should look into mental wellness and mental health instead of tackling mental illness. We should be more forward-looking, progressive, and comprehensive. In the social welfare sector, we emphasize rehabilitation model. We talk about whole person care. We don't just see the patient as a patient, to segregate the patient and treat the patient. If it is about healing, it's not just medicine. It is about the whole community. We should cover different areas of the community. It is not just the cooperation between the social service sector, the medical sector, and the education sector. It's also related to working time and also working hours and also social policy. Recently at Manpower Panel, we discussed working hours. Hong Kong has the longest working hours in the world. And long working hours thus affect mental health. We're talking about person in situation. And also, we're talking about problem in structure. We need to look at the whole social structure, how close, how deviate, how unhealthy it is. In an abnormal society, mental health is mental illness is the normal response to an abnormal society. Now, there are 200-odd pages with 40-odd recommendations. The recommendations do not mention any recommendations on implementation, and no recommendations on budget, no recommendations on timetable and roadmap. Many years, they have been asking for consultation, evening consultation for many years. It's not a problem of money. There may not be adequate psychiatrists. Even if you have a clinic, the evening clinic, there are no doctors. Now, if you don't plan, then you don't have enough doctors after 2 years. If you don't face up to it, if you don't plan, you don't have enough doctors even after 10 years. This is not the first time there is no adequate psychiatrist. People have do the sums, over 30 psychiatrists in Hong Kong. The WHO provides a ratio of 1 to 10,000. In Hong Kong, it is 1 to 20,000. Let us don't quote Australia, which has 1 to 8,000. This is the best. Do you have a plan? Any indicator? Now it's 1 to 20,000. We have over 200,000 mental patients. When will it be reduced to 1 to 10,000? Do you think 1 to 8,000 is not your target? Tell us so. How would you respond to the indicator set by the WHO? Mr. Xiu, can you give her some time to respond to your questions? The Undersecretary, manpower indicators, any implementation plan, financial arrangement, action plan.
Undersecretary, thank you, Mr. Xiu, for his comments. We fully agree with Mr. Xiu. If you refer to the report, we also said that we also quoted the WHO saying that without mental health, there will be no health. We acknowledge this, and that is why we have put forward the recommendations. You may feel that apart from the recommendations, you'd like to know more about how the recommendations can be implemented. This report serves as a blueprint. We have set out the recommendations, and we need the manpower. We need details to implement the recommendations. I think timetable and roadmaps as suggested by Mr. Shiu will be prepared by the units responsible for implementation. We may not be able to generate a roadmap and timetable for each of the recommendations, but I believe the units for following up on these recommendations will do them. And you've talked about long-standing problems, and you have waited for many years, and still there is no improvement. In the past few years, first of all, we have been working on this review and this blueprint, and I think the HA can also supplement. They have begun to take a pragmatic approach and improve their work. There may still be room for improvement. That is why you have this impression that there is still so much more to be done. We have published a report anyway. The Standing Committee will also monitor the work of various units so that we can implement all the recommendations. Ms. Alice Mack, Chairman. First of all, as far as the report is concerned, I see a lot of figures quoted, but when it comes to the standing committee to be set up, or when it comes to participation by family members, I don't see enough being mentioned. In terms of the patients and patients' family members and carers, they're being neglected, because the report only focuses on patients. Because according to the patients, the family members also suffer from a lot of pressure. We need to talk about the family members, because in many cases, the important elements are not just treatment, but also recovery with the support of family members. But these family members also need support to be carers. Otherwise, the road to recovery may be affected. So I think you need to review the content. You need to place emphasis on the needs of carers and family members. Yes, there is a subsidy available, but the support is not sufficient. I believe the deputations already gave you their views. Second point about the caseload of case managers. I think many members already covered this point. I think the crux of the matter is that we do not have sufficient manpower or financial resources. So this may be the problem at this moment. The question is, what plan does the administration have to resolve these problems? If you can't do it this year, then will you be able to do it next year? I don't see any progress, and I think everybody understands the problem, but the report doesn't point out the solution. Thank you, Ms. Alice Mack, for your question. I think some members may want more information from this report. It is not that we do not have any plan at all, but the plan will be drawn up by the units, by the service units. The Food and Health Bureau attaches great importance to mental health, and will also deploy resources to increase healthcare manpower and service level. I thank members for reminding us that we should draw up a plan at a later stage will report to members. As for participation by family members and carers, just now some deputations and some members already talked about this, and in terms of the number of family members participating in this regard, and the carers will pay more attention to that. I still have some time left. Just now a deputation mentioned that in the community many people are unsure how these problems should be dealt with. We do have interdepartmental meetings among different departments, including the housing department and police. Still, we don't know how to handle the matter. Say in the middle of the night, if the housing department is aware of somebody living alone in a flat, and then in the middle of the night this person may be engaged in a lot of causing disturbance to neighbors. We're not suggesting that we should call the police and have his marks deducted so that he can be driven away from his home. But when asked the housing department whether they have approached a helper to help him, the housing department would just say that they're not the social welfare department. For the frontline staff, the easiest way may be to deduct marks from him or to call the police every time, but this is not what I want to see. I think at the community level, you should talk to the frontline staff, be it the housing department or other colleagues. I recall that when I was the deputy chair of a district council, in my constituency, a case involving a mental patient happened. And then the HA did not send any representative to the meeting. In the end, the housing department and the police attended the meeting. And that's a very bad situation because we wanted the problem to be resolved. All right, we note this problem, and I'll see if the Labour and Welfare Bureau has anything to supplement. At the front line, after years of experience, if there is a person suspected of having mental problems, the HD will refer this case to ICCMW. And we have also arranged for seminars and talks on referral matters and people with this condition. And I also deal with a lot of these cases. I agree that we should not summons the police at once because there will be great resistance. Very often we would dispatch a social worker to get in touch with the person because it is difficult because very often the patient may not have insight, and we need time to build a relationship with the patient. We need to conduct home visits. But unless the patient is causing great disturbance, the police will not be called. For frontline colleagues, we do have a referral mechanism among the social welfare department, the police, and us. And if the condition is serious, there will be a referral to our frontline unit for follow-up action. Whereas educating frontline colleagues in the housing department and the police will continue to do that. Thank you. Mr. Long Kwok-hong. Chairman, I just bumped into a mental patient recently, so please do something about it. Someone kept scouring another person's Facebook and then stalked the Facebook's content, and when the other side ignored him, he just said that I can't take it anymore. But what's wrong with not responding to him? I think this is a obsessive-compulsive disorder. Under Secretary, please treat him. This patient is called C.Y. Leung. I think Hong Kong is having a big problem now. Please do something about it. Please talk to Chief Executive. See if the family members need help. We can give you support. This is really coming from the bottom of my heart. Stop messing around. Second point on manpower. I think Ms. Ellis-Mack rightly pointed out the issue. Training a doctor is difficult. Training professionals is difficult. Whereas for family members, they really want to help their own family member. Have you helped them? I think you can groom such carers. I haven't heard of any case in which a family member would just reject the patient. So my question is, how much have you invested in helping a mental patient recover? You said that the focus is on community care and daycare to provide the necessary inpatient service or residential service. There is no mentioning of carers and family members. I think that in times of war, they are the civilians. Why don't you invest more? Why don't you provide more training? This gentleman said that the Social Welfare Department will provide suitable training to the Housing Department. How about the Food and Health Bureau? Any suitable training to help those people, be it enhancement of knowledge or financial help? I think you must invest more, a lot more, because these are the people already there. You just need to mobilize them or activate them. Second point, if there is no mental health, there will be no health. I think no health without wealth may be more suitable, because this is what's happening now. We don't have sufficient money. We have $30 billion earmarked for this financial year. Have you thought about how the $30 billion should be used? You talked about a high-level standing mechanism. It may be a high level, but it's not comprehensive. You don't have any representative from education or bureau, because for education and housing, they are driving people crazy in Hong Kong. Education, for example, TSA is driving parents and children crazy, and for those living in subdivided units, and even for those living in public housing, they're driven crazy. You may not know, Under Secretary, there is somebody living upstairs of my home, and every night at midnight he would be using something like a chopper to chop and create different noises. I did not have the heart to call the police. Anyway, on the use of drugs, etc., I'm not in a position to say, but you need to mobilize the community. That is why when you want to do something about the $30 billion fund, you need to have a high-level standing mechanism to get funding. Say if the LegCo members, the family members, the users are all complaining, then not until then will you take out money from the pool. So I think, Chairman, somebody should write a resolution to urge the Bureau to apply for funding, because they have earmarked $30 billion. Mr. Leung Kok Hong, Dr. Fernando Cheung just submitted a motion. You can just take a look and, if necessary, add to his motion. Under Secretary, anything to add? Why don't you provide training to the family members?
I
think Mr. Leung for you. First on money, and then HA and LWB will speak on the support to family members. Mr. Leung is right. We should give more resources to the service. In 2011-12, there were about $3.4 billion to mental health. In 2016-17, we added about 40% to $4.7 billion. As for the ICCM dubs, in 2016, we spend more than we will spend more than $330 million on them, and an increase of 120% in 2017-18. We increased the annual recurrent funding of the HA by $73 million to augment their mental health service. Is it enough? We believe more is needed. We hope that whether it is under the Standing Advisory Committee or whether it is within the units of the HA, in terms of enhancing services, the Bureau will fight for more resources for strengthening mental health services. I hope the LWB will speak on training of family members. Every year, we have regular meetings. We have 2 meetings with representatives of family members. We collect the views of the users and family members for the enhancement service. As for supporting family members, within the 7 clusters, there are patient resource centers. The patients and family members can go to the resource centers to seek resources for support. As for community psychiatric service, our case manager and community nurse, our case managers and community nurses will provide support to the users and the family members. But there may not be structured service to family members. Do you have an app? You can have different apps for them. Mr. Leung, perhaps the Bureau will have to consider your view to provide training to family members. We still have a deputation who has just arrived, and I will give the floor to him. But I will give the floor to 2 members first, and then Dr. Kwok, and another member, and also a second round for Dr. Chang. There is also a motion by Dr. Chang. We can further extend our meeting to 1:15. Dr. Kwok. Chairman. This is a long-awaited report. I think the Undersecretary knows this. A decade or so ago, there was a motion asking the administration to review mental health service. The 200-odd page report gives little help. I dare not say there is no help. Now, there's a need to increase manpower, and there's a need to increase money. How much money will you add to this? How many new bodies will you add to the service? Now, the recurrent expenditure is about 8.5% of the budget, but this is less than 0.25% of GDP. As for mental health service, if it is poor, then the cost will be more than 5. I think the Undersecretary knows this. You save a little bit of money, but the the social costs will be much higher. Yet the administration is short-sighted. 8.5% is a large sum, about $50 billion. But as for the NIH, 13.5%. In Australia, that's about 0.5 to 1% of GDP. You allocate more resources to prevent the problem. Say if they can't work, then the family members will have to care for the patient. The whole family have to pay the cost to care for the patient. And then the third issue is the structure. Well, Dr. Koh will not stay. Well, I may have to congratulate Professor Chan. You will be the secretary. But you can't just rely on the policy secretary. We need a mental health authority you rely on a statutory body providing the direction. That's the first point. Dr. Tan is here. I have a question for her. For a patient, how much time is spent on attending to a patient? Say in an ordinary psychiatric appointment, is it 8 minutes? Now there will be more new medical graduates. Has the administration given you any guideline or indicator to employ adequate doctors and get them trained to be specialists? What about the supply of nurses and clinical psychologists? What performance pledge will be there? Please do not repeat your points on the non-specific items. Be more specific, okay? Well, I can answer your question just precisely. As said in the report, there are 40-odd recommendations, and they all require resources, they all require manpower. Now we have added some resources to mental health service. In the long term, there must be an increase in resources. From prevention to treatment to rehabilitation. Well, let me interrupt. Is there any target? What is percentage to GDP and percentage to the budget of the HA? Is there any target? We don't have it at present, but we hope that the Standing Advisory Committee will discuss this. As for manpower, we have resources. If we need training of manpower, Dr. Kwok has put it rightly that in 2018, 2019, there will be more new medical graduates. In terms of psychiatrists and psychiatric nurses, if we are to implement the recommendations, we need to add our manpower. Can more time be given to Dr. Tan? Dr. Ip just referred to several minutes, but he was not specific. Being the boss, can you tell us how many minutes are devoted in consulting a patient? Well, that's about 8 minutes per person on average per patient for old cases. Now, if you know the patient is stable, you spend less time, but if a patient needs more time, then even if it's an old case, you may spend half an hour on the patient. It's depending on the clinical situation. The psychiatrist will adjust the consultation time. Sometimes a psychiatrist will have to give up his or her lunch in order to attend to a patient. As for a new case, we will spend about an hour on a new case. And if, say, you spend more time on an old case, you may have to spend less time on the new case. We don't have adequate resources. We were only able to fill up the vacancies left over by some of our old colleagues. And we hope that in 2018-19 we can have more new psychiatrists. The supply is not able to catch up, as far as I know. Mrs. Regina Yip. My question is very straightforward. As for clinical psychologists, there are about 400 odd of them. They are inadequate. The number is inadequate. Now, I've heard the problems of children and adolescent mental health services. Will you talk to the universities and add more places? Clinical psychologists, supply of clinical psychologists. I thank Ms. Ip for the question. Now, the Education Bureau was also represented in the review committee. We talked to them. We refer to the shortage of supply of clinical psychologists. They have a review on that, but we don't have any information in this regard. As for the number of clinical psychologists, this is considered by the triennium for university funding. This is similar to the supply of nurses and doctors. The issue of clinical psychologists will be taken up together in that triennium assessment. Say, for example, the Hong Kong U will have the diploma courses for training clinical psychologists. We'll seek information from the Education Bureau. I support Dr. Cheung's motion. I cannot stay, but I don't think you need my vote. I have to go now. I think Mrs. Yip has shown her position very clearly. Dr. Cheung, you may now ask your second round of questions. I want to be specific. The support for self-help self-help groups has been reduced. The money given to self-help groups is limited. With the increase in number of self-help groups, the share per group will be reduced. I want to ask the SWD. Now, the LWB is not represented. The Social Welfare Department is only the executive department. It has no say on policy. In the next financial year, will you ask for adding more funding for self-help groups? Yes, we have been paying attention to self-help groups all the way. We have not cut their resources. About 3 years ago, there were only about 9 million per year for self-help groups. About 3 years ago, we had 5 million. Therefore, there will be about 15 million per year. The number of self-help groups has not increased. In fact, we provide the allowance according to the proposals they've given. Those who have got more, of course, will not speak up, and those who have got less have made a complaint. But we have not cut the subvention. Some have got more, some have got less, and some have got about, say, $400,000 in 2 years' time. We'll continue to monitor the situation and will fight for resources if need be. Is there any need to add resources? I think it's hard for Mr. Kong to answer questions. The bureaus it's the bureau's question. Now we have adequate, we have the quorum to deal with the motions. Therefore, let us deal with the motions first, and then I'll allow the deputation, another deputation, to express his or her view.
So let's start with Dr. Fernando Cheung and then Mr. Siu Ka-chun. Please go through the motions with us. As there is a lack of planning for mental health, there is a greater and more serious gap in terms of service and demand. There is a lack of a comprehensive policy and philosophy. There is serious stigmatization in the community on mental health or mental problems. This panel urges the government to upgrade the Standing Advisory Committee proposed in the report on the review on mental health to a steering committee, interdisciplinary steering committee under the leadership of the Chief Secretary for Administration to formulate, promote and monitor a comprehensive mental policy on mental health and the relevant service planning, including manpower, land training, service resources, study development to improve mental health in Hong Kong. What about Mr. Siu Ka-chun's motion? Well, Mr. Leung Kwok-hong made the suggestion, but I didn't have time to amend my motion. I think I can write another one. And meanwhile, we can deal with Mr. Siu Ka-chun's motion. All right, let me read it out. Well, about the review on mental health, there is a recommendation to set up a standing advisory committee, but the report hasn't set out, hasn't stipulated the mental patients, family members and carers as members of this committee. This panel urges the administration to invite family members and carers as members of the committee at the suitable proportion, such as 1/4. If there are no other comments on these motions, let's proceed with his motion first. Do you think we should vote on this motion? Any objection? If there are no comments, then about Mr. Siu Ka-chun's motion, anyone in favor? Any objection? Any abstention? All right, this is unanimous. Members unanimously support Mr. Siu Ka-chun's motion. Dr. Fernando Cheung is amending his motion. Is it ready? Yes, please read it out and then we'll photocopy later. At the last sentence, I have added this part to support the carers and family members. Let me read out once again. As there is a lack of planning on mental health, there is a serious gap between service and demand, and there is a lack of a comprehensive policy and philosophy, and there is serious stigmatization in the community on mental health. This panel urges the government to upgrade the Standing Advisory Committee proposed in the report to interdisciplinary steering committee under the leadership of CS4A to formulate, promote and monitor the comprehensive policy on mental health and relevant service planning, including manpower, land training, resources, study development, as well as support for family members and carers, so as to improve Hong Kong's mental health. All right, so this phrase has been added to the last sentence. You will be given a photocopy of the motion. If there are no comments, we can also deal with Dr. Fernando Cheung's motion now. Photocopies will be distributed to members later. Does anyone do members agree with this motion? No abstention, no objection. So I see that members support Dr. Cheung's motion. I hope that the government will consider these two non-binding motions which have been passed by this panel. There are some members who cannot attend today, or some deputations which cannot attend today. We have the Hong Kong CSS submission and other submissions, and for some other deputations they may be otherwise engaged. And Ms. Kwan, you now have 3 minutes to address the panel. Good afternoon. I believe that you have received submissions and other deputations have spoken. And I agree that there should be a high-level organization to dedicate this effort on mental health. And I'd like to respond to what the gentleman said, Mr. Fong. For the self-help organizations, some of them are actually experiencing difficulties. I hope that you can create a bigger pie for us to share, because you've tried that before, so please try. Because after deducting salaries, allowances, there is little subsidy left. We find even the operation of the organization difficult. We need to join hands. to tackle the problem of stigmatization. And I think it's all about formulating a policy and implementing the policy so that we can eliminate discrimination and stigmatization in the community. And we should start with primary and secondary schools. There should be public education and publicity so that they can also exercise fundamental human rights. I think in terms of differential treatment, the EOC can go through the legislative amendments. Because of the EOC's limited remit, it cannot proactively engage in the legislative amendment exercise. I hope that more help can be given, because if the policy doesn't reach a high level, if there is no comprehensive review, if there is no comprehensive policy but just a one-page document, then it won't do. We don't have the specific details. You may have the vision, but you need to tell us how you can implement the recommendations. Thank you. Thank you, Ms. Kwan. I think that we have fully discussed this issue, and I think the administration has listened to the views of different deputations on drugs, manpower, family members, and other issues. And also please pay attention to the motions moved by Dr. Fernando Cheung and Mr. Siu Ka Chun. Thank you.